you so much. So today I'm presenting my thesis project, the impact of gender on access to surgical care and clinical outcomes, particularly in pediatric surgery cases in Central and South Asia. Recent estimates indicate that a significant portion, around 11% of global burden of diseases attributable to surgically treatable conditions. Shockingly, in low and middle income countries, up to 85% of children may have a surgically treatable condition by age 15, underscoring the urgent need for equitable access to surgical care. Despite this pressing need, approximately 5 billion people globally lack access to surgical care, with the extent of this gap among children and the specific requirements for pediatric surgical procedures remaining largely unknown. Numerous factors contribute to the limited access to surgical care in developing countries. Those includes gender disparities, socioeconomic status, and the cost of treatment. Females face significant barriers to accessing healthcare, with gender biases evident at every stage of healthcare journey. For example, there are literature that shows these biases, and I want to mention. The first study that comes from Karachi, Pakistan, shows that about 199 patients were admitted for elective surgery from February to April 2010, and they wanted to identify the presence and causes of delay in accessing surgical care. And they found that the odds of delay between onset of symptoms and seeking initial health care was twice as likely for women than for men. And statistically significant reasons for the delay were lack of knowledge regarding the treatment options and lack of knowledge about the disease complications for females. Another study, which was a systematic review, and it was aimed to study gender differences in the prevalence of blindness, cataract blindness, and cataract surgical coverage in India, shows that among persons aged 50 years and above, the prevalence of blindness for men was 4.17%, and that for women was around 5.68%. Women had 35% higher odds of being blind and 69% higher odds of being cataract blind. But women had 27% lower odds of getting cataract surgeries. They concluded that in women, around 35% of prevalence of blindness and 33% of prevalence of cataract blindness attributed to their gender. In pediatric cases, also gender biases persist, affecting the utilization of healthcare services for children. A study in India shows that female gender is an important determinant of non-compliances with pediatric cardiac surgery. Out of 100 boys and girls with congenital heart defects, for every 70 boys who have an operation, only 22 girls undergo surgery. In this prospective studies, parents or guardians of 405 children aged up to 12 years old were studied, and 44% of girls had undergone surgery at the age of 1 year compared to 70% of boys. And when they studied and asked the parents, independent predictors for non-compliance with surgery included female gender, lower socioeconomic class, and higher cost of surgery. In an in-depth interview, they find out that the future matrimonial prospects of girls coming from smaller society and lack of social support emerged as a major factors responsible for delays in undergoing surgery. Another study aimed to find the demographic characteristic of caustic substance ingestion and its outcome in children in Afghanistan shows that the p-value of gender and complication stayed very significant. It's showing the association that most female patients are getting complicated, and the mean frequency of dilatation of different genders showed a p-value, a significant p-value, which again shows that families were not interested to continue the dilatation treatment for their female child. It's not just that at the stage of society and families that females face the gender biases. Even healthcare professionals themselves may exhibit some gender biases impacting clinical practices. For example, a study in Israel regarding the attitude and practice of physician in prevention of coronary arterial disease shows that physicians in general considered that male patient to be at higher risk and prescribe aspirin and lipid-lowering medications more often for the male patients. And evaluation of medical records for these patients shows that with patients with baseline low-density lipoprotein cholesterol, which is more than 110 milligram per deciliter, 77% of males receive lipid-lowering medication compared with only 47% of females patients. And the p-value again stays significant for this. The evidence for gender biases in the attitude as well as in actual practice of secondary prevention towards patients with coronary artery disease exists. While the problem of male patients receiving lipid lowering medication appears appropriate, that the proportion of women receiving such treatments still remains undesirable. So recognizing the deep-seated social factors underlying these biases, my research project aims to investigate the impact of gender on access to care and clinical outcomes in common pediatric surgical procedures in Central and South Asia. Through a systematic review and meta-analysis following the PRISMA guidelines, I'm analyzing the patient demographics, surgical procedures, outcomes, complications, recovery time, and long-term outcomes. While also I'm gonna search for factors such as parental decision-making and healthcare providers if available on the data. The targeted region for my study is Central Asia and South Asia, including these countries on the slide. And then for eligibility criteria, I'm including all those articles that mention the socio-demographics of patients, data from Central and South Asia, all languages, and the articles that mention clearly between 0 to 18 years old of age. Gender-specific diseases and case reports are going to be excluded from my study. 2 independent reviewers are screening currently the articles, and we are getting there. It's under process. The initial result shows that after searching the database, we have around 8,004 articles. Around 6,000 at the moment is being excluded. Around 2,000 is included in this study, and 400 we have conflicts. Thank you so much. That was my presentation.